Okay, so great. Khadeen, can you just indicate that you can actually, that I'm audible?
Yes, it looks perfect
Okay.
and sounds perfect. Thank you.
Perfect. Thank you so much. So I would like to extend a warm word of welcome to everyone that's logged onto this call. Today we will have a look at some aspects of CMML, and I'll introduce the speakers very shortly. Just a reminder that these sessions are recorded and that the recordings are available on Blood SA's website, so you can check it out under resources, click on deep dive. If you have any questions or comments, which we would encourage, please, you can type them into the chat, or you can unmute and speak at the time when we do the question and answer session at the end.
Sorry, Johan, I can only see the welcome slide. Yes, there's the...
Good. Just a reminder that CPD points will automatically be submitted to the HPCSA for each attendee. Unfortunately, you will have to stay for an hour to qualify for your CPD point. So just take a note of that. And if you have any queries about your CPD points, you can contact Melanie Davids, and her email address is shown on the screen now. In terms of Blood SA, they value feedback on the presentations, and that is an anonymous feedback, which you are able to do at the end when you log off the call. So please, we encourage you to do that. You cannot do any queries because it's anonymized, we can't act on that. So don't use it for that. The management team of Deep Dive, of course, is Stel Verbrugge, Khadeen Kritzinger and Melanie Davids, and we would like to again say thank you very much for the hard work that you put in making this a reality. So then on the agenda for today, we will look at CMML pathology. Dr. Piet Wessels will speak to that, and then there's a clinical case presentation by Dr. Liesen Berzenberg, and then I will say something about leukemoid reaction following cardiac surgery in CMML. Just to let you know, next week, the topic under discussion will be idiopathic multicenter Castleman's disease. So I'm not going to say anything about myself, but I just like to introduce both of these speakers, the other speakers, briefly. Dr. Piet Wessels actually needs no introduction, of course. He is a certified clinical hematologist and has been a hematopathologist for many years before that. He currently works at AMPATH at Life Groenkloof Hospital in Pretoria, and has been in the industry for more than 30 years. He is affiliated with the Department of Hematology and Medical Oncology at the University of Pretoria, and his interest is thrombotic disorders in adults. And then I think new on the scene today for the first time on Deep Dive is Dr. Liesel Berzenberg. She's a senior medical specialist physician and intensivist in the Department of Internal Medicine at the Steve Biko Academic Hospital and the University of Pretoria. After qualifying as an intensivist, she completed postgraduate diplomas in healthcare simulation and patient safety at the University of Galway in Ireland, and also ultrasound postgraduate diploma at the University of Pretoria. And she's passionate about healthcare education and simulation, as well as medical point of care ultrasonography. So that about our speakers. And just so that you can see what she looks like, of course. There she is. And then again, just the CPD points will automatically be submitted to the HPCSA. And I'm going to stop sharing my screen, and I'm going to ask Piet that you share your screen and you can continue with your presentation. Thank you so much.
Thank you, Johan. Okay, so this case today is going to be on a patient that was diagnosed with CMML about 2 years prior to his presentation in the intensive care unit where I worked. You can go to the next slide. Okay, so I'm going to take you through the pre-operative course, and then the few days that he did spend with me in ICU, we'll discuss day by day. So the patient, I was asked by the cardiothoracic surgeon to assist with the perioperative management of a patient, a 59-year-old male who was pre-operative for a 4-vessel CABG the next day. He had developed chest pain during strenuous exercise, and an angiogram done by the cardiologist revealed extensive LAD disease with a significant severe occlusion at the trifurcation. Now, this patient was really of sober habits. He lived a very healthy lifestyle, very active. He followed a keto diet. No known allergies. In terms of background medical history, nothing of note. Chronic medication, all that he was on was Wellbutrin and Dormanoct. At the time, he was using a supplemental vitamin C. And as I already mentioned, that 2 years prior to this presentation, he had been incidentally diagnosed with CMML without ever being symptomatic at all. And at that stage, preoperatively for his major surgery, he was not on any treatment for the CMML. Next slide, please. So on physical examination, there was nothing of significance, no organomegaly, no generalized lymphadenopathy. He did not appear pale. His vitals were normal, and the preoperative bloods that were done showed a reasonable hemoglobin of 13, hematocrit of 41.9. He had a macrocytosis of 102. White blood cell count was elevated at 14.47, with an absolute monocyte count of 4.20 with a normal platelet count. And the morphology comment at that stage, there were no blasts present, no platelet clumping on the peripheral smear, no leukoerythroblastic picture, and no teardrop cell. Next slide. So the day of the surgery, post-operatively, I went to see him. He had spent a considerable time in theatre. He was almost 6 hours on pump. They had done a 4-vessel CABG, and they harvested both the greater saphenous veins as well as the internal mammary veins. And he was still intubated post-operatively, albeit on very little sedation. He managed well and cut well on his ventilatory support on minimal settings. But what was already significant is that he had profound vasoplegia post-op. They actually struggled to get him off pump. So he was on double vasopressor support with phenylephrine and noradrenaline running at quite considerable doses. The sedation was stopped, as I already mentioned, in order to allow the patient to wake up and start triggering the ventilator spontaneously, because the aim was to wean him as soon as possible and extubate as soon as possible. The pain pump was running. Patient had minimal amounts of myocardial fluid running as maintenance. And on the vasopressor support, the vitals were stable. And just because I had a feeling that something was going to hit the fan later, I asked for surveillance blood cultures to be done right at the onset of his post-operative course in ICU. Next screen. Okay, so day 1 post-operatively, the patient was awake. He was successfully extubated the day before. He was, however, still on vasopressor support with the phenylephrine running at 80 mL an hour and noradrenaline running at 23 mL an hour. On that, he had a decent blood pressure of 125/52 with reasonable maps to ensure adequate peripheral perfusion. Pulse rate of 109 was sinus rhythm, and he had been extubated to no from oxygen, with saturations ranging on the peripheral side monitor between 89 and 93%. with a respiratory rate of 15. He appeared pale, but he was awake and orientated. The lungs were clear on examination. No effusions clinically at that stage. Heart sounds were normal. No gallop rhythm was audible, no significant murmurs, no arrhythmia clinically or on the ECG tracing, but there were subtle signs that something was, we were in for a difficult time, because there was already signs that the urine output was tapering with a subtle increase in the potassium levels. The patient also, during the course of day 1 post-operatively, became progressively more dyspneic and with minimal exertion desaturated to saturations in the lower 80s. And the decision was then made to switch him to high flow nasal cannula oxygen, which he tolerated quite comfortably. And based on recommendations made by the hematologists, we started doing baseline ultrasound of the spleen with serial follow-up monitoring daily to see whether there was splenomegaly developing. So on day 1 post-op, the spleen size was 10 centimeters within normal limits. So as you can see, day 1 post-operatively, the morning I was met with a very unfortunate full blood count. The white blood cell count had shot up from 14 to 100, with the absolute monocyte count shooting up from 4 to 50. As you can also see, the lactate dehydrogenase also was quite high for baseline 309. And the urea and the creatinine was also not normal, with a decline in the GFR from baseline. So the comment on the morphology at that stage on the morning full blood count was that there were abnormal monocytes present with pro-monocytes noted. There was a possibility of blasts, but the blast percentage could not accurately be assessed. The recommendation was then made to repeat the blood parameters in the early afternoon or late afternoon, early evening rather. And to 120, and the monocytes were hovering, the absolute monocyte count was hovering at 42. The LDH was creeping up ever so slowly from 309 to 337. But you can also appreciate that the urea and the creatinine was on a slippery downward slope. Next slide, please. So the patient became increasingly acidotic, metabolic acidosis, not so much a lactic acidosis. The urine output was dwindling and he became hyperkalemic. CBV-HDF was instituted earlier than later. The plan was not to take off any fluids, but to target an equal daily balance. And in consultation with my hematology colleagues, we decided, and based on the increase in the white blood cell count with the absolute monocytosis, the decision was made to start the patient on hydroxyurea. Dosage there, apologies, is incorrect. It was per kilogram, 100 milligram per kilogram, so it amounted to about 2 grams twice a day. Allopurinol 300 milligram daily for us to monitor the uric acid levels on a baseline. And throughout the course in ICU, it actually remained normal. At baseline, it was 0.2. White blood cells, the aim was with the start of the hydroxyurea to see whether we can decrease the white blood cell count to at least 20% over the next 12 hours. Serial monitoring of the LDH, white blood cell count, and monocyte count was advised twice daily, as well as to measure the splenic size daily with focus, because the concern was that the spleen would increase in size dramatically, and in the back of our minds, we were really scared of a possible splenic rupture should the spleen increase to exorbitant size. At that stage, the decision was made to defer starting decitabine. There were no place for steroids at that time. Leukapheresis was discussed, but also deferred. Reason being that the patient was already on the hydroxyurea, and with the leukapheresis, there is significant risk of associated hypertension and arrhythmia. And the patient was already on vasopressor support, and following cardiac surgery, patients are at risk of arrhythmias anyway. So one would not want to aggravate or increase the risk of the patient developing arrhythmia. So leukapheresis was placed on the back burner. And then naturally to observe the patient for signs of the hyperleukocytosis or so-called leukostasis syndrome, which would include the features of progressive or sustained hypoxia, acute kidney injury, which he clearly already had, but we can discuss the different causes and etiologies for that at the end. Neurological signs, which would then include somnolence, confusion, cerebrovascular impedance, that visual disturbance, and then naturally arrhythmia. Next slide, please. So day 2 post-operatively, his vitals were stable, still on vasopressor support, but he had now developed a very large left-sided pleural effusion. And so big that it actually compressed the left lung with compressive atelectasis, impairing oxygenation. He was severely dyspneic on minimal effort, and the cardiothoracic surgeon placed an intercostal drain. Patient was still on CVV HGF at that stage, still maintained on high flow nasal cannula oxygen to meet his oxygenation target. He really desaturated with minimal effort, as I already mentioned. Positive thing was that they managed to wean him off phenylephrine, but he was still on minimal amounts of noradrenaline, weaned to 4 moles per hour, and the spleen state was 11.7 centimeters, so it had increased by a centimeter, or almost 2 centimeters in the space of 2 days. Next slide, please. So here again, you can see the progression in terms of the blood parameters on day 2. So the morning value, we had so he had been started on hydroxyurea the day before. So the next day, after 24 hours on hydroxyurea at therapeutic doses, the white blood cell count was 170. Apologies. In the afternoon, it dropped to 70, so we were starting to have some hope. The monocyte count also came down, and the LDH was stationary. Next slide. So day 3 post-op, early in the morning of day 3, the patient developed atrial fibrillation. Synchronous cardioversion was performed, which was successful, and the patient was started on a maintenance infusion of amiodarone. And when I saw him, he was actually doing well, and he managed to mobilize to the edge of bed for the physiotherapist. But what was of concern is that he appeared very somnolent. And that day, also the spleen had increased in size, and it had reached size of 13 by 16. Next slide. Again, comparing all the blood parameters, so the white blood cell count was neither here nor there, was no significant decrease. The absolute monocyte count had also plateaued, so to say. But which is of interest is that the LDH was progressively creeping upwards. So that day it was 1,347. Next slide. So on day 4, The patient was stable once again, maintaining adequate vitals on ever still on vasopressor support, but it was not industrial amounts of noradrenaline that he was on, and hyponasal cannula oxygen was still we were still meeting our oxygenation targets with that. So the decision was made to continue with the hydroxyurea until our target white blood cell count is reached, which was less than 50, but also at that stage to watch out for neutropenia. Again, at that stage, there was no indication for any therapeutic steroids or leukapheresis. Once again, I did surveillance blood cultures because the PCT and the CRP was creeping upward. The surveillance cultures that were done on admission to ICU came back negative. But in view of the increase in the CRP and the PCT, I decided to do another set of blood cultures, and at that stage, decided also to start a very broad spectrum antibiotics, pending the outcome of the cultures. Patients were still on CVD-HDF, and the spleen was now 13 by 7 centimeters. Next slide, please. So day 5 post-op, the patient started showing signs in keeping with the leukostasis syndrome, profoundly so. He had decreased vision. His wife reported hallucinations. He was very somnolent, difficult to arouse. Still maintaining his sats on hyponasal cannula oxygen, but we were unable to wean him off. And during the course of day 5, his work of breathing increased. The left-sided intercostal vein was still in situ and was still draining quite a significant amount of pleural fluid. But now the right-sided filled up with a massive pleural effusion with underlying lung collapse. So now we had to manage that. Like I said, we had the patient on empiric antibiotics in the cultures of the new set, and the spleen again, 1 centimeter larger at 14 by 7 centimeters. Next slide, please. So again, just a serial follow-up of the blood values. You can see in day 5, not a really significant drop in white blood cell count. Same going for the monocytes, but again, something that stands out for me is the increase in the LDH, 1399 the morning value, and at that stage, even shot up to almost 2000. Renal function was also deteriorating, in spite of being on adequate setting with regard to CVD-HDF. And you can also see the PCT and the CRP going up despite negative cultures at that stage, and broad spectrum antibiotics that covered both gram-positive, gram-negative organisms as well as fungi. Next slide, please. So day 6 post-operatively, the patient unfortunately demised. We required an intercostal drain for the right-sided pleural effusion, and shortly after, the cardiothoracic surgeon placed the drain. He had a cardiac arrest with an unreported blood pressure, and despite full efforts of optimal CPR, no ROSC was achieved. The final day bloods revealed that the LDH had actually increased to almost 3,000. White blood cell count was still relatively the same as the previous day, monocytes the same, but the CRP and the PCT had shot up, as well as the urine creatinine. And then post-mortem, the blood culture results came out for the cultures done on the day of the demise, which showed a Proteus mirabilis, but which was a very sensitive organism and was actually covered by the empiric antibiotics that had been started 2 to 3 days prior. So to summarize, the clinical problem list of this patient was that we were dealing with a 59-year-old patient that had a diagnosis of CMML made 2 years prior, that now presented with an acute coronary syndrome requiring a coronary artery graft. He spent almost 6 hours on pump, which is quite a prolonged period of time, and developing a leukostasis syndrome post-operatively with significant neurological impairment, with somnolence, the fact that we could not see, the persistent hypoxia, requiring ever increasing FiO2 and higher flow on the hypomagnesemia oxygen. The persistent vasoplegia. So initially one could possibly attribute the vasoplegia to the time that the patient spent on pump, but the persistence of the hypertension with the inability of the team to wean the patient off vasopressor support was quite a significant feature. And also with the acute kidney injury, with the renal dysfunction worsening on adequate dialysis, and the development of arrhythmia in the form of atrial fibrillation all fits the clinical features associated with the leukostasis syndrome. One could potentially argue that there were several reasons for the patient to develop a kidney injury. He had contrast administered during the angiogram preoperatively. He spent significant time on pump, and that an ischemia reperfusion injury could also be likely. Signs of neurological impairment, one does not know, what could have happened intraoperatively. With a progressive leukostasis, one would also consider the plugging of the microvasculature with the elevated white blood cell count, causing microinfarcts, but the patient was too unstable to sent to the MRI. The development of the sympathetic effusions, and then the persistent hypoxia, which could have been attributed to so many things. But I see that with leukostasis, they actually say that a falsely low PaO2 on arterial blood phase analysis is quite frequently found, and that they actually advise clinicians to rather use peripheral PaO2 levels of falsely low leukostasis in his stool. So as everyone can see, it was a dismal outcome, not quite unexpected, anticipated, definitely, but very little one could do in a condition with a 40% mortality. So I'm handing over to Johan.
Thank you so much. I'm going to share my screen. So just get it in presenter view. Okay, great. So this we're touching on leukemoid reaction following cardiac surgery in CMML. And actually, what I wanted to do is to label this beware leukemoid reaction following cardiac surgery. So the outline is I want to add to what Liesel has done in what has been published in case reports of leukemoid reactions in this setting. Then I will just again remind us what hyperleukocytosis and leukostasis is all about. And then let's look at perhaps some of the causes that could contribute to the myelomonocytic leukemoid reaction and leukostasis in this context. And then I think one interesting thing that was highlighted in my reading was the TET2 variants, and I think that they are important here. And then leukostasis treatment recommendations, and then perioperative management considerations that I think that may be valuable, and then just concluding remarks. So the first case presentation is has been published in 2018, and it was a 70-year-old female patient that was that was symptomatic because of aortic stenosis. This patient doesn't have CMML. The patient only had aortic stenosis. And the procedure that was done was a surgical valve replacement with a tissue valve. The white cell count before surgery was 10.9, and the surgery or the procedure was uneventful. But on day 1, the white cell count is increased to 43. The patient developed atrial fibrillation and a right pleural effusion and persistent leukocytosis, and the effusion was drained. There was extensive workup to check for infectious causes, and the patient was transferred to the ward. On day 5, the white cell count went to 50,000, but the patient was discharged, and the blue tracing on the right shows you what the white cell count did. And if you look at the pre-surgery white cell count, at the time when the patient was discharged on day 13, it was twice that level. So patients that have cardiac surgery can have a leukemoid reaction. That's the take-home message of this. Now we're moving towards patients that are, in fact, having CMML. So this was a 53-year-old male patient admitted with painful splenomegaly. He was known to have CMML, and the clinical course was characterized by the rapidly rising leukocyte counts. He had cutaneous infiltrates, respiratory insufficiency, and also neurological symptoms. So if you have respiratory insufficiency and neurological symptoms, you're always worried about leukostasis. So the patient had excessive hyperleukocytosis with monocytosis, and this led to microcirculatory obstruction, vascular endothelial damage, and organ malfunction. It could not be prevented by low-dose chemotherapy. He got cytosine arabinoside twice, and the patient finally died from pulmonary and cerebral hyperleukocytosis and leukostasis. And interestingly, in 1997, this was labeled as an undescribed complication of CMML. So this was spontaneous in the course of this patient's disease. He didn't have any surgery to bring it on. And if we look at just basically a graph that illustrates the cause of his disease related to specific and supportive care, we can see that the white monocyte count was ever increasing, the white cell count was ever increasing, the LDH was increasing. The only things that were actually on a downward spiral was the red cell count, of course, and also the platelets for which he had transfusion. And the thing is that in the recommendations, we look at initiation of chemotherapy as the preferred measure in patients with leukostasis. Then we're looking at patients that actually had cardiovascular surgery that have CML. The first is a publication in 2007 by Drury. This was a 70-year-old male patient that presented with angina, and he had 3-vessel disease. He was scheduled for CABG, and his preoperative blood white cell count 14.2, monocyte count 1.6, and he was diagnosed for the first time with CMML at the time of his evaluation preoperatively. So he was treatment naive. He was on the pump for 76 minutes. The course of the surgery was uneventful, and shortly after the surgery, on same day basically, the neutrophil count almost increased by 4 times, monocyte count 2. The patient was still fine. He was extubated and transferred to the ward, where later the day he presented with hypoxia, oliguria, and metabolic acidosis. He was readmitted to ICU. The plan was non-invasive ventilation, inotropic support. But unfortunately, you can see on day 2, the white cell count has gone up double that of day 1. Same with monocyte count 3 times, that the patient was still hypoxic, oliguric, low cardiac output state. And what was seen is that was not a cardiac cause for the low output. So the cardiac origin has been excluded, and they thought that the patient had sepsis or splanchnic ischemia. He was re-intubated, mechanically ventilated, inotropic therapy was given and increased actually. It was continuous venous filtration, and broad-spectrum antibiotics were started. But unfortunately, despite maximum therapy, the patient deteriorated and died. The post-mortem findings were that of an enlarged spleen with widespread inflammation, and it was manifesting as pulmonary congestion with patchy hemorrhagic necrosis of both the small and the large bowel. The next patient was one of 3 as a case series that was published in 2019 by Patel. So the first here is a female in her 70s. She had CMML type 1 and comorbidities, hypothyroidism and depression. And she presented with a left hip fracture after a fall. Her white cell count was 5.5. The monocyte count 0.5. The LDH within normal range. Interestingly, she had TET2 variant, also SRSF2 variant. So this was a somatic mutation. She had the hip arthroplasty. It was done. And what is important is she was cleared for surgery by the hematologists. And why I'm presenting this today also is because consultative hematology will bring these cases to your doorstep, and you're going to have to make a call about the suitability of patients to go to theatre. So on day 1, the patient presented with hemorrhagic shock because of a hematoma. The white cell count is increased to 346, with a monocyte count of 44. LDH has gone up to 1,200. The patient developed leukocytosis, and the hematoma was basically evacuated. And then the patient decompensated rapidly. She was transferred to academic center, intubated, pressor support, antibiotics. But she had respiratory failure, shock, and basically the patient went into cardiac arrest and died. And then at the autopsy, what was seen was basically that the patient had this leukostasis that involved, I think you can see that the central nervous system. So that was basically the brain in panel A, and the heart in panel B, the lungs in panel C, and the spinal cord. And in fact, a lot of other organs actually was also similarly affected. But the bone marrow at the autopsy has shown hypercellularity with trilineage hematopoiesis, multilineage dysplasia, but the patient didn't have any evidence of basically transformation to acute myeloid leukemia. The next patient is a male patient that had aortic valve stenosis. He was diagnosed previously with CMML 0. He had comorbidities of hypertension and hyperlipidemia, with a white cell count of 20 baseline, monocyte count of 2.6, LDH of 247. Again, same mutations, TET2, SRSF2, now RAS mutation, KRAS. So he was destined for an aortic valve replacement. We underwent that uneventfully, and again was cleared by hematology before surgery. On day 1, you can see the white cell count is increased to 119 with monocytosis, increasing leukocytosis, respiratory failure. He was intubated, pressure support, died, unfortunately, the next day. And then the last of the 3 patients in that case series, 86-year-old female patient, CMML1, hypertension, kidney disease, cardiologic evaluation for heart failure. So she was destined for cardiac catheterization. The monocyte count was 0.6, the white cell count 9.9. It was an uneventful procedure, but post-surgery, the white cell count went to 104, monocyte count 8.3. The patient was volume overload with pulmonary opacities on chest radiograph, admitted to ICU, treated for pneumonia and volume overload, but they weren't able to wean her from the high oxygen requirement. So leukostasis was expected to be the cause, and they instituted hydroxyurea and decitabine. You can see that the white cell count has come down, and she was weaned off and she was discharged home. So the first positive outcome almost in all of these. I'm only going to go through this case very briefly. The patient actually had multivessel coronary artery disease with a low-risk CMML, had a cabbage done. The time on pump was 150 minutes. It was uneventful. The white cell count went up to 59.7, and the patient had fluid-resistant, rapid progressive hypertension, hypoxia, oliguria, lactic acidosis, and was again, on 4 vasopressors, which were sequentially initiated. The patient was intubated, lots of other adjunct therapies were given, and then they started to wean the patient from vasopressors. But what happened in this instance is that in addition to the supportive care, the patient was given 3 doses of Actembra. So the Actembra was given 8 hourly, and the patient was the next day no longer vasopressor dependent, but was still receiving continuous renal replacement therapy, was extubated. But unfortunately, they said the patient died on day 28 of unrelated causes. But at least there was some improvement in this patient. Black tracing in this graph shows the mean arterial pressure that has improved. It shows how the vasopressors were weaned. And these were the doses, the time intervals at which the doses of Actembra was administered. And this is something that we have to keep in mind, I think. So if we think about hyperleukocytosis and leukostasis, leukemoid reaction is, of course, a leukocyte count more than 50 accompanied by increased neutrophil precursors in the absence of basically leukemia, the causes other than leukemia. And hyperleukocytosis is total leukemia, blood cell count of more than 50 or more than 100. That's variable in literature. And then I think the medical emergency is, of course, the leukostasis, where the hyperleukocytosis becomes symptomatic. And this is commonly seen in mostly acute myeloid leukemia, characterized by extreme elevation in blast count and decreased tissue perfusion. But we also see it in chronic leukemia associated, and it may be associated with high mortality if we don't get a rapid reduction in the leukocyte cell mass through either cytostatic drugs or leukapheresis. It's not only the number of white cells that is a problem, also the rigidity of the monocytic cells. And it's been shown that if in myeloid leukemias, it's about 14% of cases of AML that develop hyperleukocytic syndrome. Whereas if you think about CLL, it's less than 1%. And that's based on the size of the cells, for example, also. It doesn't change a lot in terms of rheology. In addition to the rigidity of the cells, what also causes insult to injury in CMML is increased adhesion of monocytic cells to endothelial vessel wall via the cytokine-induced leukocyte adhesion molecules, often VCAM, and also the ability for extravasation into the microvascular space and also invasion. And then there's also clustering, local aggregated leukemia cells on that endothelial barrier as a function of the release of cytokines that adds insult to injury. I've included this table to remind us what the most frequent causes of leukemoid reactions are. And of course, it's mostly seen in infection, about 48%, ischemia and stress, 28%, and inflammation, 7%. But what we are looking at, of course, is now malignancies, especially hematological neoplasms. So what is the cause of the myelomonocytic leukostasis that we see? And there are multiple contributors in this space, especially associated with CMML and cardiac surgery. So I think the surgical trauma that stimulates local inflammatory cascades and then engage clonally derived monocytes and granulocytes to be released from the bone marrow into the circulation. And this recruitment can propagate the leukocytosis and the leukostasis. And it is unpredictable in CMML, and it correlates poorly with the number of blasts in the peripheral blood. So you never can tell. The second thing is probably the cardiopulmonary bypass, which also triggers pro-inflammatory processes, leading to increased chemokine and cytokine release. And that is directly correlated to the duration of this bypass surgery. And then I think there's also dysregulated host response in patients with CMML. And we think about damage-associated molecular patterns, for example, toll-like receptors and so on. So I think if you look at all of these things together, it resembles multi-organ dysfunction that is generated by two things, and that's systemic inflammatory reaction syndrome, SIRS, and ischemia reperfusion injury. The exact mechanism, pathways, and pathophysiology is complex, and it remains unelucidated. But I think if we think about SIRS in cardiac surgery, I think what is important to appreciate is that it causes the release of pro-inflammatory cytokines, interleukin-1, 6, 8, tumor necrosis factor alpha. And I think those are the important things to keep in mind. And interleukin-6 is, I think, central in this whole syndromic development. And it's been associated also with the pulmonary adverse events. And I think the variant that I want to highlight that was really an epiphany to me was the 1011 translocation 2 gene that's located on chromosome 4. And we know that this actually is the protein is actually promote DNA demethylation. I'm not going to speak to all of this. I think we're running out of time. I'm going to allow Pete his portion of the session. But what is important, if we think about TEC2, it's important for self-renewal of stem cells. It is important for lineage commitment and terminal differentiation of monocytes. So that's where it plays an important role. We know that it's recognized as a tumor suppressor gene as a function also of the demyelinization function. And it is a sufficient cause of myeloid and lymphoid malignancies if there's a deletion, especially that has been shown in murine models. But whether the patient's homozygous or heterozygous, it has been associated and entrenched in human hematopoietic malignancies. And the next slide shows you that you can get it in anything from AML to myeloproliferative neoplasms and CMML. And it depends, because it's a passenger mutation, on the actual driver mutation like that JAK2 V617F, what it is going to become. What is important, however, is that in CMML, it's up to between 50 and 60% of CMMLs will express the TEC2 variant. So this is very frequently seen. So why is it important? Because of this. It changes the T helper environment, upregulates T helper 1 and T helper 17, but downregulates T regulatory T cells, increase interleukin 17, and by doing so, it increases the inflammatory cytokines, pro-inflammatory cytokines. It bedevils basically plasma cell development, and also reduces immunoglobulin and immunoglobulin light chain production. And it also, in terms of macrophages, stimulates pro-inflammatory cytokines in terms of interleukin 6 and interleukin 1B, which we know are important. So I think it plays a central role in this whole development. So I've taken this from up to date, and this is basically an algorithm with treatment recommendations. If the patient do develop leukostasis, what should we do? Two things: specific and supportive care. In terms of specific, we want to lower the white cell count, and induction chemotherapy is preferred over both hydroxyurea and leukapheresis. If you don't want to induce chemotherapy and you want to delay it, if the patient's symptomatic, you can use leukapheresis in addition to hydroxyurea. But if the patient's asymptomatic, you're going to use hydroxyurea rather than leukapheresis. And then in terms of transfusion, if the patient requires red cells, you should actually avoid that, but you can transfuse it just slowly. You have to replace platelets and coagulation factors in those patients with the deficiency. And tumor lysis syndrome, of course, needs to be prevented. So I think those are important features. What about in the setting of vascular surgery in CMML? I think what is important, hematological consultation and close daily follow-up of peripheral blood counts for at least the first week, and that can be both as inpatient and outpatient, depending on what the patient's situation is. Early institution of hydroxyurea, allopurinol, IV fluids, I think is very important, and you're going to have to follow the patient. You have to apply a low threshold for admitting patients as inpatients to observe and look for leukostasis. And I think what is evident is the patients with myeloproliferative variant of CMML and those with the RAS pathways that had an increased risk of leukostasis. And I would to add these mutations that I have now already alluded to in terms of TEC2 and SRSF2. And then anti-inflammatory agents directed against cytokines like Atemra are things that we should actually consider using. What about pre-operative drug control? I think that's important, but at least 2 of the patients that were in the case series of Patel were using hypermethylating agents, decitabine, and didn't seem to modulate the outcome at all. So I think enter something like Javaki, and I think that we should look at that as a potent downregulator of interleukin-8, for example, in this context. And there's a lot to say perhaps for steroids as an anti-inflammatory agent. I know that we're always a little bit worried about healing that may be delayed and so on, but it may have a lot of beneficial impact on recovery because it can cause hemodynamic stability, less vasopressor support, lower risk of atrial fibrillation, shorter duration of tracheal intubation and length of stay. It reduces nausea, vomiting, shivering, and so on. But what is also important, it is able to traverse the blood-brain barrier effectively. An alternative is off-pump cabbage. I'm not going to say more than that because it is tolerated better. And then ultimately, I think we need a systemic study of surgical morbidity in this setting. So just to conclude, patients with CMML undergoing cardiac surgery are at increased risk of complications. They may respond in a catastrophic and unpredictable fashion. The pathophysiology is not completely elucidated. I think the subtype of CMML should be risk assessed, and I think that may be beneficial in terms of both molecular and phenotype. And then I think off-pump should be considered, and perhaps cytokines such as interleukin-6 may be a target for future use. I am done, and I'm going to stop share, and I'm going to ask Pete to do his presentation. By the way, if you have any questions or comments, you can post them in the chat. We'll be dealing with them very shortly. Pete, are you speaking? I can't, you're not audible.
Dr. Wessels, I think you are muted.
He's not muted, Z, but I can't hear him.
Oh dear.
What did you do before that made you audible, Pete? Can we do that again?
Can you hear me at all?
Yes, now I hear you. Thanks.
Fantastic, wonderful. Ay, 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 ay. I'm really challenged this afternoon with the computer. Anyway, so I'll quickly try and just give a background to and everything what everybody said. Let me see if I can advance. I can't advance, so Johan, if you can advance maybe the slides.
I'm also available to that, Dr. Wessels. For some
Can
reason, I
you-
also slide
For
control.
I can't, you've given it to me. I click on it, it doesn't work. So
No,
you
I'm
can,
not for some reason, so I will do it. And if there's a problem,
thank
Johan
you,
is
you can advance it. I'll just say next. Let's quickly go next. So I'm acutely aware of the fact that there are various people on this Zoom meeting that can give this talk in a much better experienced way. My interest is really thrombosis and hemostasis, but I had the first contact with this patient, and I suppose that's why I'm here. If you're old enough, like me, you start with history. I won't keep you that long with all those things, but I'll highlight what has been said this afternoon. Can we have the next slide quickly? So this is the history. I'm not going to talk a lot about it. Bottom line is, all along you can see the development of the entity of chronic myeloid monocytic leukemia. Myelomonocytic leukemia, you can see in 76, it was a really the FAB group that defined it. And from 2001, next slide, from 2001, the WHO is really looking after the classifications. And we all know the 2016 classification. And in 2022, two new classifications came out, the WHO New Blue Book classification and the ICC, which is the International Consensus Classification of Myeloid Neoplasms. I'll show you a little bit about that. Next slide, please. So this is what it's really all about. You'll see in the middle between the myeloproliferative and the myelodysplastic disorders, there's a group of disorders, and these have been defined in 2016 as the CMMLs, the atypical CML, juvenile MML, and these abnormal MDS-MPN combination syndromes. Next slide. So what CMML really is, it's a disorder with myelodysplastic and acquired disorder, a hematological disorder with myeloproliferative and myelodysplastic features. And it's mostly seen in older adults. I think it's often undiagnosed, and for several reasons. It's non-specific clinical presentation, it's misclassification, either as an MPN or an MDS, and it's often seen in very old patients where people would say, you know, this guy is so old, let's just give him supportive therapy. It's more seen in males, you can see that. The incidence is about 1 to 2 cases per 100 of the population per year. There's no definite specific environmental exposure link, but the epigenetic alterations that account for the CMML prototypes support this. And Johan has been talking about the production of cytokines. So these cytokines being produced actually install and cause the progression of the disease. There are therapy-related CMMLs, about 10% of cases, and the latency is the median is about six years post-chemo and post-radiotherapy. There's also an entity called secondary CMML, where it arises after an MDS. And the important thing to realize is associated with autoimmune disorders and chronic inflammatory conditions. So it's really a condition associated with that. And in the younger patients, you often have these other germline mutations like RUNX, GATA, and you can see those. Next slide. The clinical picture, as I said, non-specific, asymptomatic. You can see in a routine full blood count, you see a monocytosis. Because of this inflammatory response that these patients have, you see the polyclonal gammopathy. They can present with renal insufficiency, and that's because they have infiltration of monocytes in the kidney and also the lysozyme release from the monocytes. And they can present with an autoimmune disorder with a monocytosis. And then the two types, they can present with a myeloproliferative type, where they have a white cell count more than 13,000, or a myelodysplastic type where the white cell count is less than 13,000. So, and this is the problem is the worst. If you had to pick one, pick the myelodysplastic type, because the myeloproliferative type is the one with a poorer prognosis. And these patients can present, about 50% of them have a large spleen because of extramedullary hematopoiesis. They can have other infiltrations. And here you can see rare hyperleukocytosis. You can see there in the middle. But look at the last sentence here. There's a GM-CSF hypersensitivity in these patients, especially if they have ROS signaling pathway, NROS, KRAS. They have this GM-CSF sensitivity. In other words, inflammation, infection, surgery will cause them to have this leukemoid reaction. Next slide. So the differential diagnosis, I'm not going through this. I'm sure all these people on this Zoom meeting due to time know when people have a monocytosis, but you can have a quick look at that. And then on the other hand, you can see what is the way to, evaluate a monocytosis. And I can suggest that you'll see the reference, how I treat chronic myelomonocytic leukemia, and on the other side, how I investigate monocytosis. I think that is the left-hand side reference is quite a good reference to read. Next slide. And this slide just sums up what you should do with a monocytosis, and you can read this article if you want to, but bottom line is you should look at the peripheral blood smear. Next slide. And this is just to give you an idea, the top picture, mature normal monocyte, below that promonocytes, below that monoblasts, upper you can see an abnormal neutrophil, then you can see atypical monocytes, and then you see a myeloblast in the bottom. Bottom line is as soon as these things become dysplastic, it's very difficult to distinguish between them. Even if you've been looking at slides for 20 or 30 or 40 years, it's sometimes very difficult, especially on a trephine. Next slide. To distinguish between the different types. And you also look at the history of the patient and the clinical picture of the patient. In other words, it's very difficult to make this diagnosis without a history, without knowing more about the patient. And I highlighted this immunohistochemistry. I think this is the one place where I think if you look at a trephine of a CMML, you will get confused because you need immunohistochemistry to really define what you're looking at. Next slide. This is the key problems in making this diagnosis, distinguishing pro-monocytes from abnormal or dysplastic monocytes and granulocytes. It can be a problem. Distinguishing CMML with an AML. In other words, you need to know how many blasts there are. And then distinguishing a hypogranular AML, pro-myelocytic leukemia that's hypogranular. These cells can look like a monoblast, and it can be difficult to distinguish. Let's have the next slide. I'm going to skip, for the sake of time, I'm going to skip this slide. Next one. This is how it was diagnosed in up to 2016. Just quickly. In other words, you need to have a persistent monocytosis, and up to recently, you had to have a monocytosis of more than one absolute number, and always up to now, still you need the percentage need to be more than 10% of your white cell count. And these patients shouldn't be having a CML, myelofibrosis, polycythemia vera, or essential thrombocytosis. In other words, you need to do the JAKs, etc. You need to do a Philadelphia chromosome. You need to look at the morphology. In other words, it should fit, not with one of those. And then you also need to make sure that the tyrokinase abnormalities are excluded if there's a eosinophilia. There should be less than 20% blasts in the blood and in the bone marrow. And then you need dysplasia. And if you haven't got dysplasia, you need an acquired clonal genetic abnormality, or the monocytosis should have been present for 3 months or longer, or you shouldn't be able to find a reason for the monocytosis. This was difficult. This made it, if you look at this, there are many gaps here. And next slide. So I'm happy to say that the new WHO classification makes it much more easier. There are 4 prerequisite criteria. You can see an absolute monocytosis, but now the absolute monocytosis is 0.5. In other words, because we have other complementary tests that we can do, we know that we can make the diagnosis earlier. In other words, an absolute monocyte count of 0.5, relative more than 10%, blast still less than 20%, otherwise it's an AML, not meeting the diagnostic criteria for the other CML, P, Vera, etc., and not meeting the criteria, as I said, for the tyrosine kinase fusion abnormalities. And then you have, in other words, you need for this diagnosis, you need the prerequisite criteria, and you need If you have a monocytosis more than one, you need only one of the supporting criteria, and the supporting criteria is dysplasia, acquired clonal cytogenetic or molecular abnormality, or abnormal partitioning on the flow cytometry. I'll show you now what I mean with that. And if the monocyte count is less than 1, in other words, more than 0.5, between 0.5 and 1, you need 2 of the supporting criteria. This makes it much easier to diagnose CMML than in the previous 2016 classification. And Johan has already showed you the 2 types, the myelodysplastic type, where you have less than 13,000 white cells, and the myeloproliferative type, when you have more than 13,000 white cells. And the patient had a myeloproliferative form of CMML and not the myelodysplastic one, as I said. The old classification of a CMML 0, where you have less than 2% blast in the peripheral blood and less than 5% blast in the bone marrow, that's gone, doesn't exist anymore. So now you have a CMML 1 and a 2, and you can see the criteria there. Next slide. This is the ICC classification. The big difference between the two is that the ICC classification leans heavily on the neogeneration sequencing and cytogenetic abnormalities. And you can see here that you need about a 10% allele frequency. And that makes it, it blurs it a bit, but it's a different way of looking at it. And you'll see that they even have a further delineation of CMMLs. But the big thing to realize here is that with this, the ICC classification looks at, in other words, it's got the same, you need more than 0.5, 10%, you need the cytopenias if it's an MDS type, blast should be less than 20%, otherwise it's an AML. You need the abnormal cytogenetic result, for example, trisomy 8 or whatever, and then you need the presence of one of the NGS, but it needs to be the molecular abnormalities more than 10%. And if you haven't got that, then you need a higher count, or you need at least have the morphological picture or the immunophenotypic, the flow cytometry result that fits with the CMML. In other words, the ICC lean on morphology, flow cytometry, and genetics. Okay, next slide. The ICC also has 2 new additions. You can see there's something here called a clonal cytopenia with monocytosis of undetermined significance and a clonal monocytosis of undetermined significance. The difference between the two is that the one has got a cytopenia and the other one doesn't have. Let me quickly show you the next slide. Here you can see what the criteria is. In other words, this is the same as what we've seen previously. But here you have a lower allele frequency. In other words, your NGS sequencing is not 10%, it's more than 2%. But the bone marrow doesn't fit. As soon as the bone marrow doesn't fit, you will call this a CMUS, and not and if it's a cytopenia present, you'll call it a CCMUS. In other words, this is like the other abnormalities with looking at the molecular level of classification. They still have the bone marrow, they still have the flow cytometry, the cytogenetics, and the molecular abnormalities. Next slide. The bone marrow aspirate, I'm not going to go through this for the sake of time. You all know exactly what we need. We need less than 20% blast. We need the dysplasia. We need the hypercellularity. The one thing to realize is that sometimes in these patients you have abnormal plasma cells as well. You can have a mild lymphocytosis and a plasmacytosis, especially on the trephine, which can throw you off and make you think of other conditions, especially, for example, tuberculosis. Next slide. This is the trephine, and I'm not going to spend time, again, due to little time left. I think just to show you, to confirm what I said, you need immunohistochemical staining if you look at a trephine of a patient with possible CMML, otherwise you may miss it. And according to this CD34, you will decide whether it's a CMML1 or a CMML2. CD117 will help you as well, because those are the myeloblasts. You can do a muramidase, you can do a CD68, 71, and an MPO to distinguish between mono and myeloblasts. Next slide. Immunophenotyping, there you can see the markers for the monocytes. Next slide. I think this is an interesting slide. The next one. Let me just show you here. If you look at the CD14 expression and the CD16 expression, you know where the monocytes are, and you can see in a normal healthy donor on the left-hand side, some of the percentage cells that are still CD16 positive. But as soon as the cells become CD16 negative, if you have 94% of the monocytes being CD16 negative, the chances of this being a reactive monocytosis is quite slim, and you can see the sensitivity and the specificity of this criteria. And I think this helps us a lot in distinguishing between a reactive and clonal monocytosis. Next slide. Cytogenetics. You can see the cytogenetics present, again of 8, in other words, a trisomy 8, 7q minus, loss of 7, deletion Y. But the problem with deletion Y in older patients, you may see that, and then complex karyotypes. Next slide. The nuclear abnormalities, Johannes showed you this. 90% of patients with the CMML has got a molecular abnormality, and often more than one. In other words, it is critical if you think that a patient may have a CMML to do a molecular genetic abnormality screen. Next slide. Prognostic scoring. I'm not going to go into this. I'm going to just show you two. Next slide. I think what is interesting is this CPSS, and this is the CMML specific prognostic scoring system. It's really interesting. What they've done, this was the first one where they looked at the percentage blasts, that's the WHO subtype, and the FAB subtype, in other words, the number of white cells. And I told you, if you have a myelodysplastic form, you've got a better prognosis. Here you can see you get a higher point if you have higher white cells. And then the CMML cytogenetic abnormalities, and you can see down there which are the important ones. If you have a trisomy 8 or a complex karyotype or abnormalities for chromosome 7, you will get 2 points. And then if you're transfusion dependent, you also get a point. And you add this up, and then you can predict prognostically what will happen to this patient. But this didn't take into consideration the molecular abnormalities. Next slide. So that was the CPSS, and this is the newer, very interesting, and I think very accurate way of looking at CMML, where they take it's called the CPSS mole. In other words, they do the old classification, and then they add the molecular abnormalities, and then they combine that with the CPSS. In other words, you take the cytogenetic, the chromosomal abnormalities, the top table, in other words, is your cytogenetic abnormality plus your molecular abnormality. You define that as a score, you add then the CPSS, and you have, next slide, you have a very good delineation of prognostic outcomes in patients. Next slide. And if you think that was confusing, you can just download this calculator and you fill it in and it gives you an answer. It seems everybody now can download anything. Next slide. And treatment, I'm not going to say a lot about treatment because we haven't got time. I think the bottom line is, if you have a patient with a low blast count, you will do active monitoring. You can use erythropoietin, you can use cytoreduction therapy, depending on in which phase and severity the patient is. You can use hypomethylating agents, and you can do a transplant. The only way to cure these patients is to do a transplant. And you can see them various new drugs. Next slide. Which I can't even pronounce, and I'm sure you will be able to know more about this. But various new slides. Next slide. New drugs. These are some good articles. I've read them, and I was really impressed with what has been happening with CMML. And the new classification, I think, makes sense. I think if I have to sum up in 3 words what I've said, or in 3 sentences, I think CMML has moved from a relatively obscure disorder into a much more highlighted, well-defined, more easily diagnosed disease with poor outcomes if not handled correctly, and still poor outcomes if the patient's prognostic scoring system is bad. And what we were talking about this afternoon, remember that these patients are very sensitive to GM-CSF, especially if they have the RAS signaling pathway present. Sorry, Johan, that's it, quick.
Thank you so much, Pete. And I believe that is exactly so. I think that we shouldn't underestimate that. The question was, and if I look in the chat, is CMML different to the other myeloproliferative neoplasms in causing this? And I think it is different. And I think that what you've mentioned now, GM-CSF and the sensitivity to that makes it unique.
Absolutely.
And I think that the monocytes are also something that produce their own cytokines.
Exactly.
You know, and they move, and they're able to move into tissues and so on. And I think that makes it unique, and that's why we see more, I think, complications associated with this. I mean, surely we've had lots of patients that had surgery with myeloproliferative neoplasms, and you're worried about platelet function, qualitative platelet function, and those types of things in terms of bleeding and thrombosis, but not so much leukemoid and leukostasis. That is not something that has been prominent before in any of these disorders. So I think if you look at CMML, it is not business as usual. So I see Jacques said, fascinating, love to know what the mechanism is for the reaction. And I think the sensitivity to GCSF is central to that, I believe. You've seen it before in other malignancies like cervical cancer. Yes, it's on that list of leukemoid reactions. There are lots of different things. You can get it with carcinomas as well. And yes, the rise, if you can speak to that, Pete, in terms of the white cell count and monocytosis is rapid. It is quick. It happens very briskly. Preoperative or preemptive hydria, I think that's something that one should consider. But it has to be individualized because a lot of these patients didn't have a raised white cell count, and I think that is something that you have to consider on a patient-on-patient basis. Estelle Verbrugge says, what about chemo? Mitoxantrone IV for a young person. I think that's possible. I don't know, you have any experience with that, Estelle?
Hi, Johan. No, not specifically. If it's an acute, if it's an AMML, definitely yes. But those worked because the first patient that you discussed, there's some kind of weird echo. I don't know what's going on here. Not quite sure why it does this. Oh, it's gone. So the first patient you discussed had a 14 white cell count just pre-op. So I've never seen it actually, and I'm very impressed. That's all I can say. I think we're all impressed. It's an awful thing, and it's clearly something that happens. So I've seen leukemoid reactions in bad infections, and so we all see that all the time. But this kind of CMML that just flowers into something that looks to me from far away like an acute myelomonocytic leukemia, no, that I have not seen. If it's an AMML, Pete, and that's where you can also comment, then you must strike immediately if you want to save the patient. So if you have such a high white cell count, monocyte count, you're going to have tissue damage, end of story. And the longer you have it, the less chance the patient has. But giving 70-year-old chemo may not solve the problem.
That's exactly the problem, Estelle. We've seen if you give a CMML, they're also sensitive to chemo. That's the other problem.
That's why I said the
you end up with a patient flat for a long time and they die of an infection. So it's a very difficult thing to, you know, it's not, there's not a blanket to treat CMML. Each patient should be treated absolutely individually.
And also, if you look at that, Estelle, a lot of these patients were investigated for acute leuk, and they didn't transform. They didn't have increased blasts. They even had when they did the patients that had central nervous system symptoms, they checked for blasts in the central nervous system and couldn't find them there either. So I think that this is a reactive type of inflammatory. I don't know. It's just a terrible thing.
I agree with you, and that's why I said mitis and Trone, because it's where have I used it? You asked me, we use it in palliative care for AML, the blue bag. So it doesn't give such a deep cytopenia. It does bring the white cell count down, and it kind of it's quick. It's like it works for about 10 days or so. It works after a few reasonably quickly. That's just a palliative thing I used to use in Europe. I haven't actually used it much in South Africa. I don't know why. It's the type of thing that buys people time when they have got a refractory AML. So I just wondered if that little bit could help. But I just think it seems to be, as you both, all three of you have so eloquently told us, it seems to be something separate from leukemia. It's a different reaction, and that's why there is no drug that could help. No one drug.
The problem is also that this is a rare disease, and patients, even though they have comorbid disease and are more prone to going to surgeries and so on, are still rare. To do prospective type of studies is almost, well.
But honestly, I must tell you, if I have a CMML patient and I'm consulted, even a first, I would be telling them that this is a risk. I think CMML is a risk pre-op.
You would be able to tell them that yesterday too.
Yeah, but they will still operate if they have to.
They're gonna have to.
Yeah, so you will give a nuanced answer. You will say, now that I've spoken to you, I can give a much more forceful answer and say, well, there is the chance that this could happen. So that's the message. Wow.
And that's exactly what we wanted to highlight today. The diagnostic criteria is one thing, but that you need to know that if you are consulted about that, red lights, you are going to be in harm's way if something doesn't happen. Okay, I see that we run out of time.
Yes,
Thank you for your contributions, Tinus and Jacques. And I think we're in agreement that this is something that is more confined to CMML than the other myeloproliferative or myelodysplastic overlap syndromes. Good.
Thank you very much, Johan.
I think we
This
can
was a
log
great
off the
session.
call.
Thank you, everybody. Thanks, Pete and Liesel.